Perfect, good. So welcome to the Conversations About COVID seminar series. I'm Jessie Burke, Associate Dean for Academic Affairs and faculty in the Department of Behavioral and Community Health Sciences. I was really sad to miss last week's presentation, but I watched it and really enjoyed the conversation about centering human needs in response to COVID-19 and the harm reduction approach to COVID-19, and I encourage you all to take a look at the recordings of that session and previous sessions, which are available on our school's COVID-19 webpage. All right, so standard structure for today's webinar. Following my introductions, the speakers will discuss the topic, then we'll open it up for questions from the audience. And when we get to that portion, please use the Q&A function to ask your questions and I'll help to moderate. Please also note that we are recording this seminar. So it's now my pleasure to introduce our guest speakers who are both from the Department of Infectious Disease and Microbiology here at Pitt Public Health. Our first speaker is Dr. Mackey Friedman, who has worked in HIV prevention for more than 25 years. As principal investigator of the HIV Prevention and Care Project, his current work focuses on designing, implementing, and diffusing and evaluating HIV prevention demonstration projects with young Black men who have sex with men and transgendered individuals. He's also a co-investigator of the multi-center AIDS cohort study called the MAC study and PI of an NIH project assessing resiliencies among aging gay and bisexual men. Dr. Friedman is director of the Center for LGBT Health Research and helps to lead both domestic and international training programs in social and behavioral HIV-related research. Super excited to have him here. Our second speaker is Dr. Sarah Creer. Dr. Creer's work focuses on issues related to the transmission and treatment of infectious diseases and efforts to develop and evaluate and adapt socially and culturally appropriate projects. Dr. Creer has worked in the fields of sexual and reproductive health and infectious diseases for over 15 years as a medical anthropologist and a public health worker, and has worked in the US, Indonesia, and Papua New Guinea. On the HIV Prevention and Care Project, Dr. Creer serves as a liaison between the PA Department of Health, regional HIV organizations, and the University of Pittsburgh. Another project of Dr. Creer's is the STD to PrEP CDC-funded demonstration project, which assesses facilitators and barriers to PrEP uptake among individuals in Allegheny County. All of this is to say that both are experts in HIV-related research, and we're really lucky to have them with us here today and at the University of Pittsburgh. So I'm going to turn it over to Dr. Friedman to start our conversation about how the COVID-19 pandemic is affecting the lives of people living with HIV.
Great, thank you so much, Dr. Burke. We really appreciate the opportunity to speak today. Can everybody hear me okay? Excellent. I'm outside. It's a pretty nice afternoon here, a little brisk, but my internet can sometimes get unstable out here. So if that's the case, just alert me and I'll move back inside. So that said, I'm going to start sharing my screen right now. Great, so I'll be talking about the mixed methods approaches that we're taking to look at impacts of the COVID-19 pandemic, especially psychosocial impacts among people living with HIV and people at risk for HIV infection in the MAX-WISE combined cohort study. So we know that there's really solid evidence that supports a host of chronic comorbidities being implicated in higher COVID-19 severity and mortality risks. And these include, among other things, diabetes, kidney disease, hypertension, and underlying cardiovascular disease. We have not seen that HIV is an independent risk factor for COVID-19 severity and mortality, but we need to acknowledge that people living with HIV in the United States trend older, and so older age is also a significant mortality risk for COVID-19, as we know, And they also have multiple morbidities, in many cases as a result of long-standing antiretroviral treatment, which has cardiometabolic side effects. And finally, I know that we're all aware that without an effective national response, our state and local jurisdictions really wound up being on their own in developing and promoting a variety of public health interventions and recommendations to reduce COVID-19 transmission in local communities. And in lieu of testing, tracing, isolation, and support, that's TTIS, from the very beginning of the pandemic, unlike what we saw in South Korea, for example, and in China, what happened here was a real emphasis on physical distancing and work and school closures from the very beginning of SARS-CoV-2 infections in the United States. And as a result, we're beginning to understand that there are really profound impacts to people's mental health. And so we're going to be exploring that a little bit today in a population of folks living with HIV and their controls. So HIV negative individuals who still have risk behaviors and demographics that put them at risk for HIV infection. At the very beginning of the pandemic, and Dr. Creer will talk about this in depth, we were beginning to hear from people living with HIV in Pennsylvania real fear and concern about dual diagnoses with COVID-19 and what that might mean for their mortality. And certainly everybody was experiencing that fear, but we were especially hearing it from folks who had underlying conditions, including HIV infection. And what we wanted to do within this study that was recently combined between the multi-center AIDS cohort study, this long-standing cohort of gay and bisexual men, and the Women's Interagency HIV study, which is a long-standing cohort of women living with HIV and at risk for HIV infection. We wanted to start surveying folks at the beginning of the pandemic in the United States. So we constructed a questionnaire, baseline COVID-19 survey that was administered remotely, so via telephone, with participants between April and June of 2020. And have since conducted 3 follow-up surveys with participants in this large combined cohort it's 13 sites, and I won't go through them all, but we have representation across the country with a special concentration in the southern United States. And we also have a site in Pittsburgh, longstanding site that's PI'd by Dr. Charles Ronaldo called the Pitt Study. So some of the questions that some of the measures that we covered and the domains that we covered here in this baseline questionnaire that we administered were COVID-19 prevention behaviors. So what steps were people taking to reduce their risk of COVID-19 infection? Social disruptions due to the COVID-19 pandemic, and these included lost job, lost childcare, lost other sources of financial support, lost housing, became homeless, and lost health insurance and were not able to gain health insurance. So those are kind of the 5 key social disruptions that we measured. And we measured those specific to the COVID-19 pandemic. In other words, as a result of COVID-19, did you experience these following social disruptions? We looked at alcohol, tobacco, and substance use, although I won't report on those variables today. We're especially interested in medical care, mental health care, and substance use treatment disruption as a result of work closures, including clinic closures during that period, and access to transportation. And then finally, our kind of outcome domains that we wanted to analyze were depression symptoms, anxiety symptoms, loneliness, stress, and social support dissatisfaction. And finally, some of our strengths-based domains included social support and resilience coping. So our baseline research questions were to first analyze the prevalence of COVID-19 prevention behaviors, social and medical disruption, and psychosocial health conditions among the people in our cohort who are aging people living with HIV and those at risk for HIV infection. Second, is HIV status associated with higher levels of COVID-19 prevention behaviors and social and service disruptions? So are we seeing higher levels of those in folks who are HIV positive compared to people who are HIV negative in this cohort? And then finally, is the extent of COVID-19 related social disruption associated with worse psychosocial health? And I won't go through this kind of large and probably difficult to read slide, but I just wanted to show our sample here across the country, sites in Brooklyn and the Bronx, DC and Baltimore, Chicago, Pittsburgh and Columbus, San Francisco and LA, in Chapel Hill, North Carolina, Atlanta, Miami, Birmingham, Jackson, Mississippi, and kind of a satellite site in San Francisco as well. Oh, I kind of mentioned that, excuse me. And I also wanted to show on this slide high levels of adherence to COVID-19 prevention recommendations, with about 97% of the cohort saying they were staying at home as much as they could. And then just some highlights here of the sample. Total sample of 3,411 people responded to the baseline survey, representing about 85% of the active cohort. And really good distribution between HIV positive and HIV negative, both among males and females. And that's reflective of those cohorts and their sampling frames. Mean age, also indicative of our cohort, about 57. And again, high proportions of the sample reported being highly adherent to social distancing, to staying home, and then about 3/4 reported additional behaviors, including washing hands frequently. One person said, "I'm not getting close to anybody. I'm not seeing anybody, I'm completely isolating." So some interesting kind of open text responses from about 3/4 of the sample, suggesting they were doing many other things to keep their risk of SARS-CoV-2 infection as low as possible. So second, we wanted to see whether HIV status was a predictor of social disruption. And again, I won't go through this slide, but it's here in case anyone wants to kind of look at it in depth. But the highlights were that about 34% of the sample reported being unable to attend a previously scheduled medical appointment. And in our sample of men, so that's the MAC study, HIV positive men experienced more social disruption than HIV negative men, with 35% versus 30% reporting employment losses and 19% versus 14% requesting unemployment benefits. And we actually saw opposite effects among the women in this sample, where HIV positive women were experiencing less social disruption than HIV negative women. So 33% versus 43% reporting employment loss, and 10% versus 20% reporting lost childcare. And all of those data are available in that table if anyone wants to look more closely here. But it was really interesting to us here to see opposite effects by cohort. And one of the explanatory factors is that it's probably an artifact of these very different samples, and the men's sample is more predominantly white and more predominantly socioeconomically privileged. And so, but you still see in the sample really substantial, over a third of the cohort reporting employment losses. Our women's cohort contains a higher proportion of Black and Hispanic participants than our men's cohort does, and a higher percentage of folks who are socioeconomically disadvantaged. And HIV positivity confers increased eligibility for things like housing, for instance. There's a social safety net that is somewhat more available for people who are HIV positive than for those who are HIV negative. And I think we really saw the results of that in these reports of social disruption here being higher among women who are HIV negative than among women who are HIV positive. I think that's probably the most likely explanatory factor, is this greater social safety net that's available to folks who are socioeconomically disadvantaged if they're HIV positive, especially in some of these regions. This is a figure that kind of shows you those differences by cohort, where the max cohort or the men's cohort, you can kind of see differences here that look at no social disruptions in the blue, one social disruption in the orange, and then 2 or more social disruptions in the gray. And you can see higher proportions of HIV positive men than HIV negative experiencing at least one social disruption. So about 40% of the HIV positive cohort compared to roughly 32% of the HIV negative male cohort. And then differences, were higher levels of social disruption among women in general, but also higher levels of social disruption within women among those who are HIV negative. And then I wanted to kind of show this baseline of psychosocial characteristics. So looking at depression symptoms using the CESD, showing that in the whole sample, roughly a third of participants meet the clinical cutoff point for moderate to severe depression. High levels of loneliness in the cohort as well, about 29%, using UCLA loneliness brief form, and about 15% had symptoms of anxiety, and some variance within social support, where the plurality of the cohort had a sort of medium level of social support, and then actually fairly high levels of satisfaction with social support, so upper 80% level there. Surprisingly low percentage of the cohort reported symptoms of distress. And there were some differences again here within these cohorts, or by gender, as we stratified by cohort here, by HIV status, where we see that higher levels of, among men, people who are HIV positive, of anxiety, and higher levels of dissatisfaction with social support among those who are HIV positive. Whereas among women, we see higher levels of depression symptoms among those who are HIV negative, and higher levels of loneliness among those who are HIV negative, as well as higher levels among women who are HIV negative compared with women who are HIV positive of social support dissatisfaction. And that was a key thing that we wanted to look at, because, when you are cut off from your networks, I think we all know this from personal experience, how difficult it became to really develop and nurture and maintain the kinds of social support that we need to get by as humans, right? And I think that's one thing that we want to look at over time here. So finally, the last table that I'll show you is our third aim. What are the effects of social disruption on psychosocial health? And you can see here, just looking at the top category, we saw significantly higher. So looking at predictors, looking at social disruption as a predictor, we see that folks whose lives have been disrupted by the COVID-19 pandemic in these really tangible ways had significantly higher adjusted odds of depression, so about 32% higher for people who had one kind of social disruption, about 85% higher for people who had 2 or more. Anxiety, about 64% higher for people who had 2 or more kinds of social disruption, and then low social support satisfaction among those who had 2 or more social disruptions due to the COVID-19 pandemic. And then comparing max or male seronegative respondents as the reference category, comparing men who were living with HIV, women living with HIV, and women who were seronegative, or SN here. We see, again, higher levels of depression, of anxiety, of coping, low coping among women. And so I think that probably deserves further analysis and explanation. And then finally, what I wanted to show here was that if you were of low income status, so that's right around $18,000 a year or less, there were significantly higher odds of experiencing any of these psychosocial outcomes, or each of them: loneliness, depression, anxiety, stress, low social support satisfaction, and low coping. And then I'll just kind of finish off there. I also wanted to plug a qualitative survey that we're doing to really try to understand these findings and to look at effects and impacts of the COVID-19 pandemic on physical and mental health, access to healthcare, sexual health, HIV prevention behaviors among folks who are living with an risk for HIV in the US. And Dr. Krier has been a big part of that. We've completed 67 of 70 interviews. We have a lot of qualitative data, including from people who have been diagnosed as positive for COVID-19, and substantial participation from people who are experiencing financial strain. So those data will be hopefully coded and available by December or so, and we're happy to update the group on those. Additional research that we'd like to do includes trajectories of psychosocial health over time using those follow-up surveys, and then also kind of tracking pre-pandemic levels, which we have by using the same measures throughout, to look longitudinally at how the pandemic is shaping people's emotional responses and mental health responses as well. To look at COVID-19 prevention fatigue to see if those prevention behaviors drop over time. And that's it. That's supported by an NIH administrative supplement, and I will give the floor to Dr. Krier.
Thanks, Mac. All right, let me share my screen. Here we go. All right, hi everybody, I'm Sarah Creer. Happy to be here. Thanks for joining. All right, so as Dr. Burke mentioned, I work for the HIV Prevention and Care Project here at Pitt. And one of my roles is to help facilitate the Pennsylvania HIV Planning Group, which is a statewide stakeholder body. And I help facilitate the assessment subcommittee. So part of my job, one part that I love so much, is through community collaborative process with this planning body. I help design and implement statewide comprehensive needs assessments to better understand barriers and facilitators to HIV prevention and care here in Pennsylvania. Reducing stigma and discrimination that's associated with HIV status is a key strategy in Pennsylvania's IHPCP, our integrated HIV prevention and care plan. And for any of you who might have joined us for any of our HIV planning group meetings, I can tell you that I don't think there's been one meeting over the last 6 years since I started working with this project that stigma and discrimination hasn't come up in our usually every other month meetings as a major barrier. And so in 2018, the HPG identified stigma and discrimination as the #1 threat to HIV prevention and care. And I predict that we'll be working in supporting, facilitating work around assessing and also implementing interventions to reduce stigma and discrimination for years to come. And so a little background here. Oh my gosh, there we go. So in collaboration with the HPG, we developed an intersectional stigma measure to examine experiences of stigma and discrimination in healthcare settings among individuals living with HIV in Pennsylvania. For our first rollout, it's ongoing currently among all recipients of the AIDS Drug Assistance Program, or ADAP. In Pennsylvania, it's called SBBP, or the Special Pharmaceutical Benefits Program. And it aims to assess the prevalence of multidimensional stigma in healthcare settings, characterize intersectional stigma burden, and to evaluate the impact of stigma and health and well-being. I didn't know how this would look here on a slide, but this is the larger survey. And at the very bottom here, you'll see there's, I'm trained as a qualitative medical anthropologist here, and so my favorite part is actually these 4 open text questions that the HIV Planning Group Assessment Subcommittee developed, and that is what I'll be talking about here today a little bit. I actually put them on this slide as well, and here are the 3 questions that we started noticing responses, unsolicited responses that were COVID specific responses. And so essentially we started, it was a, year or so long community collaborative process, workshopping every step of the way with the assessment subcommittee. And, once we were through our various levels of approvals and felt like quite the journey, we started rolling in early February of 2020. And as we all know, things started changing pretty quickly only a few weeks later. And so Corinne Bozitz, who has been hard at work in managing this survey and its implementation, started noticing that, these COVID-related responses, in response to these 3 specific questions of what are you most worried about in your next healthcare experience? What are you most looking forward to in your healthcare experience? And what are some concerns that you may have about your future healthcare needs and options? And so we were able to take a look at all of that information. There were 19 individual COVID-specific responses from 16 individuals. And we were able to present this information to the HIV Planning Group's assessment subcommittee during our meetings in May. We also have, we were able to publish a note from the field here as well. As you see, the sample is quite small, 16 individuals, 94% identify as male, 94% as white, 75% identify as gay. The mean age ranged from 29 to 72, but the mean age was around 58. And these responses represented 4 of the 7 Rhine-White regional guarantee regions were represented. And this is a subsample of a much larger, more diverse sample of respondents. So for this note and for this presentation, we used inductive grounded theory approaches to identify some domains of concern that came up. So number 1, concerns about COVID-19 risk and worry. I'm curious about the new virus. And again, sorry to go back here. The dates, our earliest date was of March 4th, and our last date of these responses was April 14th. And so coronavirus, honestly, in plain English, I'm scared shitless of the coronavirus. In terms of living with HIV during COVID-19, this is navigating HIV-related healthcare. It's navigating COVID-19 care potentially while living with HIV. And so here's a few of the quotes from participants. Now having HIV and coronavirus, scary. I'm hoping I don't need service soon with the virus going around, and hoping and being with a compromised immune system. And this quote, I think, is particularly profound here. I'm terrified that my needs and options will become harder to have due to the long-lasting time that I'm hearing that the coronavirus will be lasting, i.e. resources will be fewer and more difficult to find. And also I'm on salvage therapy and my options to treatments are fewer and my hearing bad news becomes more. I feel like a deer facing headlights. And there's several comments around managing comorbidities, especially cancer. Everything being complicated with fear and anxiety associated with having my condition during the coronavirus period, safely arriving and exiting to my appointment in order to have a repeat biopsy is what I'm worried about. Another comment, COVID-19 and cancer returning. And lastly here, this is around the impact, as Dr. Friedman was mentioning here, around social isolation. And one participant commented here, getting by this coronavirus period of virtual isolation. Normally I go to the gym twice daily and eat out an awful lot. I, like all, am concerned about how long this situation will continue. In terms of the question around what you're most looking forward to in your next healthcare experience, 99% of my healthcare experiences are great, so I do not expect anything more than that. I changed my HIV doctors, and due to the coronavirus, I had an appointment over the phone. It was good. And lastly here, my next appointment, hopefully, is my primary care infectious disease physician. He's fantastic as my doctor and very close as a friend. He's also recognized for his intelligence broadcasting his information of coronavirus. Now, that was our first, as I mentioned, we rolled about 3 weeks before a lot of the social distancing measures were in place here in Pennsylvania. And we were able to get about, 650 responses by May. But the COVID-specific responses very much slowed down at that point. And we were able to, over the summer, actually also kind of receive the approvals to roll a second wave out and to also include ADAP recipients in Philadelphia. So it was a major, exciting new moment for us. And so that rolled out about 4 weeks ago. And this will be our final moment here for this first version of the survey. And so as of today, we have 1,430 responses for the overall survey. And just in the last few weeks, compared to the 19 kind of COVID-specific responses that we reported on in the spring, there are 100 individuals who've made about 127 new COVID-specific responses since September. And we will be reporting on all of that information in addition to kind of emerging right out of this, after we reported to the HPG in May, we were asked to put together a proposal for listening sessions, right, from what we were learning from the participants from this survey, really wanting to offer opportunities to hear how people were doing and how their health and well-being, how they're accessing services, have been impacted over the last several months. And so we actually had our first listening session this last Wednesday, and our next one is next Wednesday. And then we'll be presenting all of this information to the Pennsylvania Department of Health Division of HIV Disease and the Pennsylvania HIV Planning Group later in November. But Dr. Friedman suggested I offer a few of our, teases, of all of these more recent responses. And so cancer appears here to be still a very frequent comment and concern. As one participant mentioned, cancer or corona, the terrible C's. In terms of telemedicine, and we heard this in our listening session on Wednesday as well, one participant said, as we go virtual, it's convenient, but we lack the one-on-one. In addition, there's a growing concern, and we're hearing this not just in the survey, but also in our listening sessions and other stakeholder engagement activities about the growing concern around the possible cuts to funding. I'm worried about the loss of in-person access due to COVID-19 and SBVP, med coverage, and my Medicare Advantage program. Another participant said, I'm a long-termer, diagnosed since 1998. With all the cutting of funds, I fear HIV may be put on the back burner. A couple new domains which emerged here, looks like a loss of, one new concern, and I saw a few mentions of this over the last few weeks, the pressure to accept the COVID-19 vaccine when available. In addition, there are a few participants who mentioned a loss of insurance and employment due to COVID-19. As one participant said, I'm most concerned that since I'm currently uninsured due to a reduction in salary due to COVID-19 effects on my work's revenue, that I will either not get the treatment I need or be left with big medical bills. And lastly, what are you most looking forward to in your next healthcare experience? One individual said, I'm wondering about a cure for this and for COVID-19. And lastly, what are you most looking forward to? Human contact. There's only so much self-imposed confinement one can tolerate. So these responses, emerged unprompted, and they've covered several domains of concern that include avoidance of healthcare services due to risk of COVID infection, fears about continued access to healthcare services, the management of comorbidities, specifically cancer, and the impact of social isolation and change in routine on the mental health and well-being of people living with HIV and at risk for HIV. In addition, the utilization of telemedicine for healthcare and trust and practitioners' advice also emerged as positive domains. I know we're kind of close to time here, so I'll just wrap up. Moving forward, I think we thought this was an important opportunity, and I'll continue to try to learn and from all the responses that we've received so far. But I can tell you that when we developed the survey, and never did we expect that we'd be talking about the effects of COVID-19 on the health and well-being of people living with HIV and at risk for HIV here, and how this might impact medical adherence, medical engagement, and mental health. But that is very much the work that we have set out for us here moving forward. So happy to be here, happy to answer any questions, and also happy to return when we are able to, when we wrap up here in a couple of weeks of data collection. So, all right, thanks.
Thank you both so much for really thoughtful and presentations that cover the whole scope really nicely. I want to encourage people to submit questions in the Q&A. There are a couple there already, but before we get to them, I had a quick question that occurred to me while you were presenting, so if you'll humor me. I wondered if, especially for the work, Dr. Friedman, that you presented, are there, and I may have missed it in the small table, differences by geographic setting, right? When I think about it, not only for sort of contextual influences, but also specifically sort of COVID rates, what's going on, the situation, the response, and I don't know if you got any insights from the analyses you did there.
Yeah, it's a really good question, and we were expecting to see differences geographically, but we really didn't. In our multivariable models, region was not associated with worse psychosocial health outcomes. So, we thought it would be there, and it really, really wasn't. That's all I can tell you.
Okay, I just was curious. It sounds like you explored it and it's not there. Okay, thank you. So there are a couple questions, and I'm going to start with one that's talking about the rippling effects of pandemic on our lives, right? And are the challenges, the future challenges associated with them. And are there pieces of that that we might not see on the surface for this population of individuals living with HIV? So sort of thoughts about that, and then a question about, if so, how will we address them? Sort of what's happening now and what can we do moving forward? Either one of you want to help us answer that one?
I can just start here really quickly. And something that's actually, that's come up now in our listening sessions and also in our last HPG meeting was around employment and the loss of employment among individuals at risk for and living with HIV. And so we're already seeing that. We're already now seeing that in people's responses in this survey. And I know that we actually voted to, or the HIV the planning group voted to create a special working group on employment in our meeting in September. So I know that those, I hope that that issues that you mentioned here that we might not be aware of yet will continue to have opportunities such as venues like the HIV planning group and other opportunities here in Pennsylvania to make sure that these are being talked about and that actions are being taken to respond and support people. Mac?
Yeah, I mean, I think our data show, low-income participants experiencing such severe psychosocial outcomes. And I really feel like it's that kind of canary in the coal mine here. I mean, I speak from a real position of privilege here. I still have my job. I'm still able to put food on the table. I'm still able to, pay my mortgage. there are so many things that I'm able to do that folks who aren't in this position absolutely can't. And so, you know, I think that one of the concerns here is that our economy is built on this kind of constant growth model. And how do we as a country, how can we be resilient to effects like financial effects and their rippling psychosocial effects toward our most low income constituents who don't have the political power to argue for, you know, for appropriate interventions that are structurally based. So I guess I really worry about that. I really worry about our safety net not being up to the task. I worry about powers that be not diverting resources to people who most need them. And I worry about how that looks, you know, 3-4 years down the road. One of the things that I think we need to look at are experiences of great deprivation in you know, kind of history of our societies, and what that does to people's genomes, for example, how that changes, you know, changes our DNA and becomes congenital, how people can pass along those methylated DNA changes from, you know, one generation to the next hereditarily. You know, so I think these are really long-term effects, and we just don't know what they're going to look like. And, you know, obviously the sooner we get a vaccine and effective treatment, the better. But let me also say that there are also long-term physical effects among many people who have been diagnosed with COVID and who have recovered. And I think, you know, that's also the tip of the iceberg here. If we're talking about already a 10% COVID prevalence in the US population, you know, we're already talking about a huge number of people who are going to have long-term effects of COVID. And in my class that I'm teaching this semester, we had a couple survivor stories last week talking about their long-term effects from being diagnosed with COVID in April, March and April. And these are like, they were in their early 30s, you know, or late 20s, and they have continuous long-lasting effects just from the, you know, from the virus itself, headaches, brain fog, you know, and that's just kind of, we don't know what that's going to look like and how big that effect's going to be. So I think it's not just psychosocial, it's also physical, but they were also talking about depression and how did they deal with their changes, you know, the changes in their body due to COVID, their loss of taste and smell, not having completely recovered, and how much they used to love to eat, you know, a lot of these very kind of tangible things that they don't have anymore, you know, and they're just trying to regain. So I think we also have to consider survivorship. We have to consider loss and grief for folks who have, you know, who are losing family members, partners, you know, friends, in some cases children, spouses, due to this disease. I think the effects are hard to underestimate. And what do we need to do? I mean, I wish I had a good answer, you know, but I think, at least at the moment, I think we need to really build out interventions to help people gain the social support that they need to kind of moderate these mental health outcomes, and focus on communities who are most deprived and who are kind of losing the most to the pandemic right now.
Yeah, and I would add to that, exactly what you all are doing is uncovering and documenting all of the associated issues too, right? That the discussion and dialogue about all of this is critically important. We have to talk about it in order to then acknowledge it so that we can move forward and address it. And unfortunately, it is not, you know, a common topic or as much in our discourse, right? And so I really appreciate you all bringing that up here in the work that you do. So there's a question here that is sort of helping us to focus a bit more on our immediate setting, right? So we've talked about the US, we've talked about Allegheny County, and I think This question here is a really important one. So it's from a student who identifies as HIV positive at Pitt and is asking about what's going on campus around HIV, and then a couple of things very specific to services that are available, and we can get into some of that. And I'm happy to help connect directly if we want to about how to access the Office of Student Affairs. But what I want to focus on here is this piece of on-campus HIV efforts and supports, and then this concluding comment about COVID testing is normalized where HIV testing is still stigmatized. And I'm wondering if you can both comment on Pitt's campus and then sort of this general piece of supports. Mackey, I'm going to go with you first.
Yeah, I'm just reading through the question. I think it's I think it's fantastic. I think HIV stigma is real, and that we silence voices of people living with HIV routinely, and that another thing I'll say is that just being in the LGBTQ community and kind of being social, and living through the epidemic, I don't see the kind of attention paid to HIV, lately that I did even 10 years ago or 15 years ago. It's almost like, oh, well, they're effective antiretrovirals and, whatever, we just we're over, it's done, it's gone. But we know that's not really the case. I think people really get epidemic fatigue and they want to move on. And, I sort of understand that psychosocially, but it ignores the continuing pandemic, especially in communities of color, especially in youth communities of color, especially in youth, sexual and gender minority communities of color. And I feel like, that's a risk we also take with COVID, as COVID, like so many infectious diseases epidemics, moves rapidly, into kind of concentration among the most disparaged communities and the most oppressed communities. The majority community likes to say that they're not infected. They like to think that it won't get to them, for lack of a better word. I think we have to fight really hard against that. Related to Pitt specifically, so I don't know is the answer. And I think that a lot of the work that we've done has been sort of more national or more research-based, and we really haven't focused on the local student community and partnering with, with Pitt Student Health, for instance, to make HIV/AIDS awareness and HIV testing and PrEP available in a way that, is substantially addressing the needs of our students, especially our graduate students. So I think that's one thing that we've really failed on. But I think this is a real opportunity and to start reaching out and doing that work. I'll leave it at that, but I am absolutely happy to have more conversation. We have an LGBTQ Health Research Center, and I'm hoping that the questioner will become a part of the work that we do.
Thanks, Mac. I totally agree. And I saw your comment here about why do a lot of people not know about the U Equals U campaign? And that's a brilliant question. U Equals U is so exciting and I think has so much potential, to help reduce HIV-related stigma as well. And so please, let's be in touch, because I think, I've always envisioned or dreamed of, there's so many really cool campaigns out there right now in visuals, but wouldn't it be awesome to have a super fun and, exciting U Equals U campaign that is something that really speaks to us here at Pitt in Pennsylvania. So yeah, let's, please be in touch. One additional thing here that I've been thinking about from the very early days and I wonder, I think over time, maybe for those of us who live and work with HIV, you know, in these early days of, for example, for even like telemedicine, I remember it was like, you know, day 2, day 3 of kind of a lot of the news coverage, right? And it seemed in terms of COVID-19, it was like, telemedicine, no problem, it's done. You know, but I know for somebody who's worked with HIV planning group, we've talked about just how important, how much potential telemedicine might have for reducing people's experiences of stigma and discrimination within healthcare settings, or in the process of getting to your actual appointment. And so, I don't know, it's something I've been thinking about, and I think for maybe a lot of us who've been working with HIV before COVID-19 happened, kind of what, I don't know, you know, I think we're learning now in terms of telemedicine that it's not necessarily, you know, the best option for everybody, but I am curious and interested to see if it can help reduce some people's experiences, and hopefully support people's engagement, increase engagement as well. Thank you.
And just to clarify for folks who don't understand U or who don't know about it, U equals U means undetectable equals untransmissible. So people who are living with HIV but have been able to, through antiretroviral medication, keep their HIV viral load to an undetectable level, are not at risk of transmitting HIV through sexual behavior to partners. And so that's really been proven through the science and through a bunch of cohort studies that have looked at this. And, you know, I think it's an incredibly important campaign to reduce HIV stigma, as well as, you know, to sort of inform folks who are HIV negative about kind of sexual risk.
Yeah, thanks for that clarification. I was gonna make sure. And it is a really important question, and I appreciate that they asked it. So we'll be in touch. So I have one follow-up ask and then a question for you both. And if anybody else has questions, please pop them in the Q&A since we're getting close to our time together. But Sarah, over your shoulder, I see the acceptance journeys poster, I think. And I'm wondering if you could just tell our audience a little bit about that amazing project and where they could learn more about it.
Sure, yes, it is. I know this is actually my 4-year-old son's bedroom that is now Mama's office. So try to make it a little bit more office-like. Yeah, so the Acceptance Journeys campaign is actually something, is one of my first projects as staff, and it's a community-level intervention that strives to reduce LGBT stigma in the community in Pittsburgh. And so it's essentially the heart of this. It's something we did 2013, largely 2013 through 16. And the heart of it is something that really speaks to me, and it's about stories. It's about collecting stories from non-LGBTQ identifying individuals about their love and acceptance of LGBTQ loved ones, really kind of trying to collect as many journeys or stories so that people who might be struggling to love and accept their LGBTQ loved one can maybe see themselves in those stories and grow from them. And so that's one example of an intervention that actually was done alongside of Dr. Friedman's Project Silk demonstration project. And you know, we've been thinking in terms of, you know, how do you know, when you're assessing, you're documenting all of these experiences of stigma and discrimination within healthcare settings, the first thing that the committee is going to ask us is, okay, how do we reduce these experiences of stigma and discrimination with healthcare settings? And so, you know, how do you intervene? How do you reduce? And that's a really, it's a hard question, but one that I'm really inspired to and passionate about pursuing for many years to come. Yeah, so yeah, you're right. That's it, AJ.
And where can people find more information?
I'll put the website here.
Okay, great.
Okay. Yeah, no problem.
Yeah, so I love that project, and so it's exciting to be able to ask you about it again. So my final question to both of you is any sort of last words, thoughts about this particular topic, things that you want to share before we wrap up. For me, it was really helpful to see such a comprehensive picture and exploration of what is going on right now in terms of COVID concerns among people living with HIV. And I loved how it was centered in sort of partnered approaches, right, that you're working with, especially Sarah, for the research that you presented, that has grown out of this coalition work. And then that you're integrating, you know, I love mixed methods, right? So the qualitative and the quantitative, because I think I said a bit about how important it is to document, uncover and document, but it's also incredibly important to understand or try to understand some of the complexities, and I think that's where the qualitative really comes in. So thank you both. I'm just wondering if you have any final parting thoughts before we wrap up.
I don't, and I thank you so much for inviting us to talk with you today.
Great, thank you.
Yeah, thank you.
Great. Yeah, so my hope is that you'll come back and talk to us again when you get this next set of data. 80 plus interviews is a lot, so we can't wait to see all of it. I want to thank you both for coming today and for sharing your work and for the work that you do. And then I want to thank all of our participants for joining us on a Friday afternoon too. And I want to invite everybody to join us again next Friday. So next Friday, Mario Brown and Chantel Mitchell-Milan will join us to discuss COVID-19 and related health disparities. And so that will be an important conversation to have as well. So have a great evening, and I will see you all next week. Thanks. Thank you.